Welcome to your custom deep dive. You asked us to look into the rapidly expanding universe of, well, women's health.
Yeah, specifically this really fascinating stack of sources covering non-surgical feminine rejuvenation.
Right, and usually when we talk about a medical procedure, there's this underlying expectation of absolute precision, like engineering.
Exactly. You break an arm, the x-ray shows the jagged line, and the doctor just points at it and says, there it is, we cast it, it heals.
Yeah, it's highly binary, right? Broken or not broken. It's clean, easily categorized,
Yeah.
and honestly, that predictability is incredibly comforting.
Oh, absolutely. I mean, the human brain heavily favors that kind of linear problem solving. We want a clear-cut intervention for a clear-cut issue.
But stepping into gynecological health and energy-based therapies, that X-ray analogy just completely falls apart.
It really does. The landscape becomes incredibly nuanced. We are looking at sources today covering CO2 lasers, erbium lasers, and radio frequency devices.
And you might be exploring this stack for a whole variety of reasons. Maybe navigating post-childbirth changes or vaginal laxity.
Or managing things like mild stress, urinary incontinence. Or maybe you're experiencing the genitourinary syndrome of menopause, often referred to as GSM.
Which brings about severe tissue thinning, dryness, and painful intercourse because of that big drop in estrogen.
Right, which is why this topic is so critical to cover objectively.
Which is exactly our mission for this deep dive. We want to cut right through the glossy marketing brochures you see in med spas.
Demystify how these highly advanced machines actually work on a cellular level.
Yeah, and directly answer a highly specific, very practical question bubbling up from the clinical post-care documents in your stack. Is discharge normal after laser or radio frequency tightening?
It is a huge question.
Okay, let's unpack this.
Yeah.
Because before we can even begin to answer what happens in the days following the procedure, the recovery, the rules, we first need to understand what these machines are physically doing to the tissue during the procedure.
Right. The sources highlight two main categories. We have lasers, like the CO2 Monalisa Touch or the Air Waya Intimalaze, and radiofrequency devices like Thermova.
Let's start with the lasers, because there are two very distinct approaches here, starting with carbon dioxide.
So CO2 lasers are classified in the literature as microablative. To understand that, we need to define ablation, which essentially means the physical removal or destruction of tissue.
Wait, destruction?
Yeah. When a CO2 laser fires, it is vaporizing microscopic channels directly into the vaginal mucosal tissue.
Wow.
It takes the water inside those specific cells, instantly turns it to gas, and punches microscopic holes in a precise grid pattern across the tissue.
I mean, vaporizing tissue sounds incredibly intense, if not outright violent.
It sounds severe, yes.
Surely there's a way to trigger a clinical response without physically punching microscopic holes into the mucosa.
There is, and that brings us to the second laser type highlighted in your sources, the erbium Y, or Erwiag laser. This device takes a non-ablative approach.
So no vaporizing cells.
Exactly. It does not break the surface of the mucosa at all. Instead, it relies purely on thermal energy.
Okay.
The laser pulse drives intense heat deep into the underlying tissue, raising the temperature up to about 65 degrees Celsius.
Wow, that is hot.
Very. So rather than creating a grid of physical micro wounds, it creates a grid of intense subsurface thermal stress.
Wait, so if the goal is just heating the tissue without burning a physical hole, how does radio frequency fit into this? From my understanding, RF doesn't use light energy at all.
Right.
So how is a machine shrinking tissue without relying on a laser beam?
Radiofrequency completely changes the delivery mechanism by bypassing light altogether. It utilizes transcutaneous electromagnetic energy. A device like Thermova uses temperature-controlled RF to gently heat the tissue.
But the parameters have to be incredibly strict, I imagine.
Oh, absolutely. It is kept exclusively between 40 and 45 degrees Celsius. The device relies on thermistors, which are essentially high-tech, real-time thermostats resting against the tissue.
Keeping it in that highly specific, safe window.
Exactly. And when the underlying mucosal tissue hits that precise temperature range, the existing collagen fibers undergo a radical physical change. The triple helix structure of the collagen literally denatures.
Like it folds in on itself.
Yes, it folds in, becoming shorter and noticeably thicker.
So the heat is essentially melting the structural bonds just enough to force them to shrink up.
Right, and that immediate contraction provides an initial tightening effect. But the real goal is what happens next. That sustained thermal stress stimulates fibroblasts.
Which are basically the body's microscopic construction workers.
Exactly. Once activated by the heat, they kickstart neocollagenesis and neoelastinogenesis, which is the biological manufacturing of brand new, healthy collagen and elastin over the following weeks and months.
So it's essentially like aerating a lawn. You intentionally punch tiny holes or apply thermal stress to the underlying soil so that newer, healthier, thicker grass is forced to grow back.
That analogy perfectly captures the mechanism. You are initiating a highly controlled microtrauma to force a sluggish biological system to initiate a massive healing cascade.
But wait, I have to push back here. We are intentionally causing thermal damage and vaporizing cells in one of the most sensitive, delicate parts of the human body.
I know it sounds completely counterintuitive to basic health.
It really does. If I burn my hand on a stove, my hand doesn't grow back younger and tighter.
What's fascinating here is that the therapies are specifically designed to hijack a very specific stage of the body's natural inflammatory healing cascade.
Okay, go on.
When you create that grid of microdamage, the body rushes emergency resources to repair the perceived injury. This triggers neovascularization, which is the formation of entirely new blood vessels.
Right.
That fresh, increased blood flow brings massive amounts of moisture and nutrients, effectively restoring hydration to tissues that might have become thin and dry.
And the clinical studies in our stack mention that this regenerative process actually helps restore the correct naturally acidic pH levels, right?
Yes, by encouraging the repopulation of normal lactobacilli flora. You are breaking the tissue down just enough to trick the body into building it back stronger and healthier.
Which brings us to the biological reality of that entire rebuilding process. Because these treatments rely entirely on triggering an inflammatory healing cascade, the tissue has to physically process that trauma.
Right, you simply cannot aerate a lawn without turning up some dirt.
Exactly. And this leads us directly to our core mission for you today. What you should expect in the exact days following the procedure, specifically regarding discharge. If you read the patient forums in our sources, there is a massive amount of anxiety about this specific symptom.
It is easily the most common post-procedure concern. But the short answer, derived consistently across every clinical post-care protocol in your stack, is a resounding yes.
Okay, that's reassuring.
Experiencing discharge is entirely normal after these treatments.
And our sources describe it very specifically so you know exactly what to look for. We are talking about a watery, gray, or slightly pink, blood-tinged discharge. And the timeline varies. It typically starts almost immediately after the topical numbing cream wears off. And it can last anywhere from 1 to 2 days, all the way up to a couple of weeks.
It really depends on how aggressive the fractional laser setting was, or how deep the RF heat penetrated.
Right, but why exactly does it happen?
We just have to look at the cellular mechanics we walk through. If a CO2 laser vaporized thousands of microscopic channels, or an RF wand denatured the collagen bed, that mucosal tissue is going to mount a defense.
It's actively weeping.
Exactly. The body is shedding the dead cells and exuding serous fluid. Serous fluid is essentially the clear, protein-rich plasma portion of your blood that rushes into a wound site to soothe, protect, and carry away cellular debris.
As it repairs those microinjuries.
Yes. The discharge isn't a side effect. It is literally the physical byproduct of your tissue regenerating.
So if you are looking into booking this, or if you just got home from having it done, you can take a deep breath. Seeing a gray or watery pink discharge does not mean something has gone wrong. It means the lawn aeration is actively working.
Your body is doing exactly what the machine provoked it to do.
But I want to pivot to the flip side of that. How do you know when it is not normal? What is the strict threshold for calling a doctor? Because honestly, if I am weeping fluid for 2 solid weeks, I am probably going to get a little paranoid.
Vigilance is absolutely required. The clinical sources clearly delineate the red flags. While that watery gray or light pink discharge is expected, there are undeniable signs of complication. You should seek immediate medical advice if the discharge becomes foul-smelling.
Or if it noticeably shifts to a yellowish or greenish color.
Right. Those are classic textbook signs of a bacterial infection, not normal healing. Furthermore, while light spotting is expected, if you experience bright red bleeding heavy enough to soak a standard maxi pad in under 2 hours, that is an acute medical issue.
Wow. Okay, so that indicates a severe laceration or hemorrhage.
Yes, and it requires immediate clinical intervention.
So what does this all mean? It means knowing that weeping tissue and gray discharge are part of the normal healing process is only half the battle. Managing that profound vulnerability requires following a very specific, inflexible post-care protocol.
Absolutely. The local environment is temporarily compromised. The protective mucosal barrier has been intentionally broken down so that it can rebuild, leaving the tissue exposed to pathogens.
It sounds exactly like the aftercare for a heavy medical-grade chemical peel on your face. You have to protect that raw skin from dirt at all costs,
Hmm.
but in an environment that is naturally moist, dark, and highly prone to daily friction.
Which makes the aftercare rules incredibly strict. The universal prescription across every single source in our stack is something called vaginal rest. This is non-negotiable.
Meaning absolutely nothing is allowed inside the vaginal canal. No intercourse, no tampons, no menstrual cups.
Nothing for anywhere from 3 days to several weeks.
And the daily hygiene requirements are incredibly specific too. The sources recommend the strict use of only 100% cotton underwear, loose-fitting clothing, and entirely avoiding leggings.
Yes, to let the area breathe and minimize friction.
I saw a really practical tip across the clinic documents, using a jug of warm water to gently rinse the vulva while urinating, because the mucosal tissue is essentially nursing a superficial burn, so the natural acidity of urine hitting those microablations can cause severe stinging.
Exactly. And the rules surrounding bathing are equally strict. No hot tubs, no swimming pools, no soaking in lakes. You cannot expose that healing tissue to shared water due to the incredibly high risk of bacterial infection.
Though there is a notable exception in the literature, right? One source highly recommends soaking in a warm saline bath, like 1 tablespoon of pure sea salt dissolved into a gallon of water.
Yes, starting on the day after the procedure. The saline acts as a gentle, natural antiseptic to encourage cellular healing and soothe the raw discomfort. But you must gently pat the area completely dry with a clean towel afterward.
Absolutely no rubbing, because the tissue is incredibly fragile. And for topical care, clinics suggest using ice packs wrapped in a clean towel for the first 24 hours to manage the localized swelling.
They also recommend applying Aquaphor to keep external treated areas moist, but they heavily emphasize avoiding any petroleum-based products like Vaseline.
Because petroleum acts as a thick, impermeable seal, right? It can trap thermal heat inside a fresh burn and create a breeding ground for bacteria.
Exactly, which is the absolute last thing you want on an actively weeping wound. This raises an important question, though, regarding human behavior and how closely patients actually follow these intensive rules.
Because resuming normal activities too soon actively interrupts that fragile neocollagenesis process.
The newly forming tissue is described as friable. It tears and bleeds incredibly easily under stress. Ignoring the vaginal rest protocol is frequently what leads to the severe complications we see documented.
Here's where it gets really interesting, because we have to talk about the actual data. If the post-care is this intense and the recovery involves weeks of weeping discharge and strict abstinence, does the long-term result actually justify this grueling process?
Looking through the data in our stack, the results are wildly polarizing.
Polarizing is definitely the word.
Looking at the positive outcomes first, many independent clinic papers report genuinely glowing results. For instance, your sources highlight a case series tracking 184 patients that demonstrated a massive 92% satisfaction rate at the 6-month mark.
Wow. They reported life-changing improvements in dyspareunia, effectively reversing their painful intercourse, right?
Yes, and profound reversals in vaginal dryness and significant improvements in mild stress urinary incontinence. For many women, these devices are fully restoring their quality of life.
But then you turn the page in our stack and you hit the randomized controlled trials, the gold standard of medical research. There's a specific RCT of 88 patients that compared actual laser therapy to a sham or placebo treatment.
Basically, the doctors inserted the probe, went through the motions, but never actually fired the laser energy into the tissue.
And at the 12-week mark, the difference in vaginal dryness scores between the women who got the actual laser ablation and the women who got the sham treatment was not statistically significant.
Both groups reported feeling remarkably better.
If a gold standard RCT shows these highly advanced lasers are statistically no better than a placebo for certain symptoms, why are 92% of patients in other studies thrilled? Are we just looking at an incredibly expensive placebo effect?
If we connect this to the bigger picture, we have to synthesize this conflicting data completely impartially. The placebo effect is undeniably powerful, particularly in sexual medicine, where reduced anxiety heavily influences physical arousal and natural lubrication.
But the objective physiological changes cannot be ignored. The increased collagen density, the thickened mucosal layers seen in post-procedure biopsies, those are very real.
Exactly. The core challenge is that standardizing the definition of clinical success across wildly varying baseline health statuses is incredibly difficult to capture in a single trial.
And we also have to look at the darker side of the data, because the stakes are high. the FDA's MAN-UE database, and the safety overviews from NICE in the UK highlight some incredibly severe risks. We aren't just talking about a little extra grade discharge here.
No, the severe adverse events are sobering. The reports include patients experiencing a paradoxical worsening of dyspareunia. The intense thermal trauma induced severe pelvic floor hypertonus.
It basically triggered massive involuntary muscle spasms that made intercourse entirely impossible.
Right. There are also highly detailed reports of severe vaginal stenosis. One case detailed the vaginal canal severely scarring, causing it to shorten and narrow to just 2.5 centimeters in depth.
That represents a total loss of function for intercourse. Another patient developed crescent-shaped fibrotic bands, which is essentially thick, unyielding internal scar tissue that created a painful obstruction.
And going back to our discussion on patient behavior, the NICE overview explicitly cites cases of severe traumatic vaginal lacerations.
Caused directly by patients resuming penetrative intercourse just a few weeks after the therapy, before the newly formed collagen had regained its tensile strength.
The stark contrast between the glowing reviews and these severe FDA adverse reports proves a critical point. The success of this technology is highly dependent on variables outside the machine itself. Patient selection is absolutely paramount.
And provider skill is critical, right? Delivering too much energy causes catastrophic scarring instead of rejuvenation.
And ultimately, strict adherence to the post-care protocol dictates how the cellular matrix will heal. The margin for clinical error is exceptionally small.
So to bring it all back to the core mission of your deep dive today, if you are navigating the complex world of non-surgical vaginal rejuvenation, understand that while these energy-based devices can stimulate impressive cellular repair, they achieve this strictly by requiring controlled tissue damage.
That intentional damage naturally and inevitably results in a cascade of temporary side effects.
Seeing a watery, gray, or slightly pink discharge is a completely normal, expected sign of your body weeping cerealous fluid and actively rebuilding itself. It is the biological response you paid for.
Provided you are rigorously following the strict aftercare rules and constantly watching for the distinct red flags of infection.
Exactly.
It serves as a profound example of humanity's ability to manipulate our own biology. But looking at the mechanics leaves us with a fascinating, lingering concept to ponder.
Oh, what's that?
If we can successfully force the body to regenerate vaginal tissue by intentionally causing repetitive microdamage, what is the ultimate biological limit to this specific hack?
Wow, yeah. If a patient begins getting annual laser touch-ups at age 50 and continues that cycle for decades,
Continually tricking the mucosal tissue into repairing itself with heat and cellular ablation, is there a ceiling? Is there a definitive limit to how many times human fibroblasts can bounce back and lay down new collagen before they simply exhaust their regenerative capacity?
and the tissue becomes entirely unresponsive? That is an incredibly fascinating question for the long-term future of these therapies.
It really is.
We have essentially figured out the exact thermal temperature required to aerate the lawn, but we don't yet know how many consecutive seasons the soil can take it before it gives out. Keep questioning the science, keep demanding the hard clinical data behind the glossy med spa marketing, and remember that when it comes to your own health, deeply understanding the why is always just as important as knowing the what. Until next time.